hope our cadaver lesson gave you a great review of the upper limb. In gross anatomy, it's really important to put the regions together after studying them. Now, let's start our coverage of the lower limb by introducing its somatic nerve plexuses. Somatic, you'll recall, refers to the type of nervous tissue that governs voluntary skeletal muscle and carries conscious sensations of touch, pain, and temperature from the skin. There are 4 somatic plexuses, and all are composed of the ventral rami of spinal nerves. Remember, dorsal rami control our true back muscles and the skin down the vertical middle third of the back. Only ventral rami of spinal nerves enter into the 4 somatic plexuses, which are the cervical, brachial, lumbar, and sacral. As we learned, the cervical plexus is a braid of ventral rami from the 1st through the 4th cervical nerves, and the brachial plexus is composed of the ventral rami of spinal nerves C5 through T1. The ventral rami in the thoracic region take a simpler pattern. Each hugs a rib and is called an intercostal nerve. Now we'll take a look at the ventral rami of lumbar and sacral nerves that form the body's 2 final somatic nerve plexuses. Together, the lumbar and sacral plexuses control the muscles of the lower limb and the pelvic floor and relay conscious sensations from the lower limbs and genitalia. Let's kick things off, lower limb pun intended, with a clinical problem. A 46-year-old man was admitted to the hospital for intestinal surgery, and afterward, to ward off a potential infection, he was given a prophylactic intramuscular injection of an antibiotic into his left buttock. He quickly developed numbness and tingling in the skin of his left leg, except for the anteromedial aspect. And remember, the leg is the region between the knee and ankle. The man also lost sensation in his entire left foot, but the skin of his left thigh was not affected. Muscular issues quickly followed. He could only weakly flex his left knee and could not move his ankle, foot, or toes on the left side. Specifically, what happened to cause this problem? The lumbar and sacral plexuses have several things in common. They both supply muscles and skin of the lower limb. They both share the ventral ramus of the 4th lumbar nerve. And in addition, they both form within or more or less pass through a muscle that takes origin off the spinal column. The lumbar plexus forms in the posterior abdominal wall, posterior to the psoas major muscle, and is composed of the ventral rami of the 1st through 4th lumbar nerves. The sacral plexus forms in the posterior pelvis on the anterior surface of the sacrum, where the ventral rami that form it pass between the fibers of the piriformis muscle. The sacral plexus is composed of the ventral rami of L4 through the 4th sacral nerve. Because the 4th lumbar nerve belongs to both plexuses, some references even combine the plexuses and refer to the entirety as a single lumbosacral plexus. Before we cover the specific nerves of each plexus and generalize about the muscle regions they control, we should discuss the regions and compartments of the lower limb. As we saw in the shoulder, the gluteal region of the hip contains numerous muscles, but they aren't wrapped in fascia, so they're not compartmentalized. Within the limb, the thigh is divided by fascial planes into 3 subdivisions: an anterior, posterior, and medial compartment. Below the knee, the leg region is subdivided by fascia and the interosseous membrane between the tibia and fibula into an anterior, posterior, and lateral compartment. There are a couple of muscles on the dorsum of the foot, which is the top of the foot, and there are so many muscles in the plantar region or sole of the foot that we'll consider them in 4 muscle planes or layers. Now let's dig into the specifics of the lumbar plexus. As we know, each lumbar nerve exits the spine through the intervertebral foramen located inferior to its respective lumbar vertebra. Then each spinal nerve splits to form a dorsal ramus and a ventral ramus. The lumbar plexus is composed of the ventral rami of L1, L2, L3, and L4. These braid to form 6 nerves as well as some tiny segmental branches. Remember, a plexus's segmental nerves are small, unnamed branches that supply muscles that sit so close to the vertebral column that the nerve twigs entering them aren't easily seen. Also, unique to the lumbar plexus compared to the other 3 somatic plexuses is that all lumbar plexus nerves reach the skin to provide cutaneous innervation. Recall that the subcostal nerve is the name given to the ventral ramus of the 12th thoracic nerve. The term intercostal doesn't really fit, since the 12th rib is the final rib, so the accompanying nerve isn't actually between ribs. And while the subcostal nerve doesn't belong to the lumbar plexus, it is usually the best place to start to identify the nerves of the lumbar plexus. This is because the 12th rib is easily felt in the posterior abdominal wall and can be used to identify the broad, flat subcostal nerve. From there, the ventral ramus of the first lumbar nerve can be identified. Another structure that helps differentiate the major nerves of the lumbar plexus is the psoas major muscle, which I call the landmark muscle of the lumbar plexus. This is because some nerves are easily differentiated by their relationship to the psoas major. One nerve typically emerges from the muscle. One nerve is medial to the psoas major, while others are lateral to the muscle, as we'll see. In the posterior abdominal wall, the L1 ventral ramus typically divides into 2 lumbar plexus branches, the iliohypogastric nerve and the ilioinguinal nerve. Like the subcostal nerve, these supply anterior and lateral abdominal wall muscles and have cutaneous branches to the skin. This is the reason that the lowest regions of the torso are covered by L1 on a dermatome map. As the iliohypogastric and ilioinguinal nerves course around the low torso, they pass between the transversus abdominis and internal oblique muscles, and then eventually between the internal oblique and external oblique. Ultimately, the ilioinguinal nerve, but not the iliohypogastric, emerges from the muscle wall through a natural opening known as the superficial inguinal ring. It's in the inferior border of the external oblique. Now, this is the same opening that transmits the spermatic cord in males and the round ligament of the uterus in females. Because an indirect inguinal hernia can cause a loop of small intestine or perhaps a fat pad to herniate through the natural opening of the superficial inguinal ring, the hernia can compress the ilioinguinal nerve off the lumbar plexus and cause pain. In addition, during a hernia repair, surgeons must take care to avoid the ilioinguinal nerve off the lumbar plexus. The real braiding of the lumbar plexus begins when the ventral rami of L1 and L2 combine. Together they form the genitofemoral nerve. Typically, the genitofemoral nerve emerges from the anterior surface of the psoas major muscle. After coming through the muscle, the genitofemoral nerve splits into a genital branch that passes medially and a femoral branch that passes laterally. The genital branch of the genitofemoral nerve is of interest because it serves a muscle that is present only in males. The cremaster muscle is within the spermatic cord that suspends the testes within the scrotum. It consists of strands of muscle fibers that are derived from the internal oblique. The cremaster forms during development when the testes descend from their original position in the posterior abdominal wall near the kidneys and then travel through the muscle layers of the abdominal wall to finally assume their normal location in the scrotum. The cremaster muscle raises and lowers the position of the testes in response to low and high temperatures, respectively. Since to form properly, sperm require a temperature several degrees below normal body temperature. The genital branch of the genitofemoral nerve is cutaneous in both sexes, but the female has no cremaster muscle counterpart. The femoral branch of the genitofemoral nerve is cutaneous only in both sexes. So, in summary, the genitofemoral nerve is cutaneous in both sexes, but in males, part of it also supplies the cremaster muscle of the spermatic cord. Progressing inferiorly, the ventral rami of L2 and L3 merge to form the lateral femoral cutaneous nerve. Now, this is the only lumbar plexus nerve that is completely cutaneous in both sexes. As its name implies, it supplies the skin of the lateral aspect of the thigh. So, on a dermatome map, we see that T12 and L1 supply the skin of the lowest part of the trunk and into the scrotum or labia, but do not supply the rest of the external genitalia, for reasons we'll cover with the sacral plexus. But once into the thigh, the dermatomes transition to L2 and L3. Further, the dermatome patterns of the thigh swirl around the limb, which we didn't see in the upper limb. This is because the lower limb rotates during embryologic development. The result is that our knees bend in a different direction than our elbows, and it's why our big toe is medial, though our thumb is lateral. The final two major nerves of the lumbar plexus are derived from braiding the ventral rami of L2, L3, and L4. The largest of the pair is the femoral nerve, which is not the same thing as the femoral branch of the genitofemoral nerve. The femoral nerve is a large nerve that passes immediately lateral to the psoas major muscle and supplies most muscles of the anterior thigh. The femoral nerve also supplies skin of the anterior thigh and has a long cutaneous branch known as the saphenous nerve. Now, the saphenous nerve continues below the knee and supplies the skin of the anterior and medial leg. The saphenous branch of the femoral nerve is the only branch of the lumbar plexus that has any function below the knee. All other skin below the knee is supplied by branches of the sacral plexus. The other branch derived from the braiding of L2 through L4 is the obturator nerve. It descends into the pelvis along the medial border of the psoas major muscle before passing through the large opening in the pelvis called the obturator foramen. From there, the obturator nerve reaches the medial compartment of the thigh, where it supplies most muscles, as well as skin on the medial aspect of the thigh. And when you look at a dermatome map, it isn't obvious that three differently named nerves supply the skin of the lateral, anterior, and medial thigh. But that's because the lateral femoral cutaneous, femoral, and obturator nerves all have the ventral rami of L2 and L3 in common. Those nerves overlap to create the L2 and L3 dermatome patches that are seen on the front of the thigh. The fact that the saphenous branch of the femoral nerve goes below the knee is why we see L4 on the medial leg in a dermatome map. Two final concepts will wrap up our coverage of the lumbar plexus. First, tiny segmental branches supply the psoas major muscle itself. As we'll see in a future lesson, psoas major takes origin off the lumbar vertebrae and inserts on the lesser trochanter of the femur. Because it's located so medially in the posterior body wall, small segmental branches off ventral rami innervate psoas major. Lastly, the ventral ramus of L4 descends from the lumbar plexus and links up with the ventral ramus of L5 to create a structure known as the lumbosacral trunk. It connects the lumbar plexus to the sacral plexus, since L4 belongs to both. Recall that the lumbar plexus is made up of the ventral rami of L1 through L4, and the sacral plexus is composed of the ventral rami of L4 through S4. So, as I like to say, while we're not four-legged, think of fours when it comes to the innervation of our legs, meaning the entire lower limb, of course. The sacral plexus forms on the anterior surface of the sacrum, at the origin of the piriformis muscle, which I call the landmark muscle of the sacral plexus for reasons we'll see. The lumbosacral trunk starts off the sacral plexus, but remember the four foramina on the anterior aspect of the sacrum? They transmit the ventral rami of S1, S2, S3, and S4 into the pelvis to continue the formation of the sacral plexus. Though there are 5 sacral nerves, the 5th one does not typically have its own sacral foramen. It usually emerges between the sacrum and coccyx, which remember is the tailbone. Likewise, there's a coccygeal nerve adjacent to the coccyx, but neither S5 or the coccygeal nerve are involved with the sacral plexus. Typically, the ventral rami of 6 spinal nerves, L4 to S4, braid to form the 8 nerve branches of the sacral plexus. To understand the formation of each nerve of the sacral plexus, I like to first take the spinal cord levels in 4 sets of 3s in a pattern I call frame shifting. First, the ventral rami of L4, L5, and S1 braid to form 2 nerves of the sacral plexus, the superior gluteal nerve and the nerve de quadratus femoris. Next, the ventral rami of L5, S1, and S2 braid to form 2 nerves, the inferior gluteal nerve and the nerve to obturator internus. Then the ventral rami of S1, S2, and S3 braid to form 1 nerve, the posterior femoral cutaneous. Finally, the ventral rami of S2, S3, and S4 braid to form the pudendal nerve. Then we go back to the top and see that all but the ventral ramus of S4 merge to form the large sciatic nerve, which I'm sure you've heard of. But we'll break the sciatic nerve down to its 2 major subdivisions, the common fibular nerve and the tibial nerve. Let's talk about each of those groupings in turn as we cover the sacral plexus nerves. First, both the superior gluteal nerve and the nerve to quadratus femoris are composed of the first 3 levels of the sacral plexus, L4, L5, and S1. We'll see in the next lesson that the superior gluteal nerve supplies 2 of our 3 gluteal muscles, gluteus medius and minimus, but also supplies the tensor of the fascia lata. As for the nerve to quadratus femoris, one of the muscles it supplies is obvious, quadratus femoris, of the deep gluteal region. But for historical reasons that I'll explain in the next lesson, the nerve to quadratus femoris also supplies the small muscle known as the inferior gemellus. So ironically, when asked the question, what nerve supplies the inferior gemellus muscle, the answer is the nerve to quadratus femoris. Go figure. Our second set of 3 cord levels, the ventral rami of L5, S1, and S2, combine to form the inferior gluteal nerve and the nerve to obturator internus. The inferior gluteal nerve's only responsibility is to supply the gluteus maximus muscle, but it is such a large muscle, so that's a pretty big job. And guess what? The nerve to obturator internus doesn't just supply the obturator internus muscle. It also supplies the small muscle known as the superior gemellus for the same historical reason. More on that in the next lesson when we examine those muscles. But I should add that none of those 4 nerves, not the superior or inferior gluteal nerves, nor the nerves to quadratus femoris or obturator internus, none of those reach the skin for cutaneous distribution. On the other hand, the only nerve from our 3rd frame shift, the ventral rami of S1, S2, and S3, is the posterior femoral cutaneous nerve. Now, it supplies no muscles and is the only branch of the sacral plexus that is entirely cutaneous. Its region of supply is in its name. It supplies the posterior thigh down to the back of the knee. Our final set of 3 ventral rami is S2, S3, and S4. These braid to form the pudendal nerve. This nerve is both cutaneous and motor to the perineum, which is the diamond-shaped region between the thighs. Now, this body region is inferior to the pelvic diaphragm that supports our pelvic organs. The boundaries of the perineum are the pubic symphysis that links the 2 pelvic bones anteriorly, the 2 ischial tuberosities laterally, those are often called sit bones in yoga classes, and the perineum's posterior boundary is the coccyx. And while those 4 bony landmarks outline the diamond-shaped region between the thighs, an imaginary line taken between the 2 ischial tuberosities can subdivide the perineum into a pair of triangles. The urogenital triangle is the anterior half of the region, and the anal triangle is the posterior half of the perineum. Now, the urogenital triangle contains the external genitalia and the outlets of the urinary and reproductive systems, as well as the muscles, nerves, and vessels that control and supply those structures. The anal triangle contains the anal canal that serves as the outlet of the digestive system, as well as the muscle and neurovascular structures that supply structures in this region. The pudendal nerve off the sacral plexus is the origin for all nerves to this region, whether cutaneous to skin or motor to skeletal muscles. In my opinion, a historical not-so-fun fact is that the word pudendal comes from the Latin word for shameful. So in the 17th century, the area between the legs was our shameful zone. And while still not the subject of most polite conversations, these are obviously important regions to our body's waste elimination and sexual health, among other functions. The pudendal nerve gives off an inferior rectal branch that supplies the external anal sphincter. That's the voluntary skeletal muscle that allows us to control our bowels. It also gives off branches that supply the external urethral sphincter that controls the release of urine. For this reason, the saying S, 2, 3, and 4 keeps our waste mess off the floor is used as a memory device. The pudendal nerve also gives off branches that supply some of the muscles of the pelvic and urogenital diaphragms, and those support pelvic organs and prevent the prolapse of organs like the vagina and rectum. And it supplies muscles and sensations that help maintain sexual health and functions. By far the largest nerve of the sacral plexus, in fact, the largest and longest nerve of the body, is the sciatic nerve. It's formed by the ventral rami of L4 to S3, all levels of the sacral plexus except S4. But from the outset, even as it's forming, the sciatic nerve is really a combination of 2 nerves, the tibial and common fibular nerves. To remember their spinal cord levels, I tell my students to return to the highest ventral ramus of the sacral plexus, L4, and take the first 4 levels, L4, L5, S1, and S2, for the common fibular nerve. Then return to the top and take the first 5 levels, L4, L5, S1, S2, and S3, to remember the cord levels of the tibial nerve. So start at the top each time, but first time take 4 for the common fibular and then take 5 for the tibial nerve. After all, L4 and L5 make up the lumbosacral trunk that links the 2 plexuses. Both the tibial and common fibular nerves contribute to supplying the skin on the posterior leg. In terms of motor supply, the tibial portion of the sciatic nerve supplies the bulk of the hamstring muscles of the posterior compartment of the thigh and all muscles in the posterior compartment of the leg. As we'll see, the tibial nerve splits at the ankle to create the medial and lateral plantar nerves, which together supply all muscles and skin of the sole of the foot. The common fibular nerve supplies a portion of one of the hamstring muscles we'll study, and then, just inferior and lateral to the knee, the common fibular nerve splits into a superficial fibular nerve and a deep fibular nerve. Now, the superficial fibular nerve supplies the muscles of the lateral compartment of the leg, as well as most of the skin of the anterolateral leg and the dorsum of the foot. The deep fibular nerve supplies the muscles of the anterior compartment of the leg, the muscles on the dorsum of the foot, and a small patch of skin between the big toe and second toe. That branch is sometimes called the flip-flop nerve because that skin is where the tether in the open-style footwear, often called a flip-flop, would sit. Before leaving the sacral plexus, I'll add that you really can't sort out its nerves within the pelvis, where it forms on the anterior sacrum. It's not until you can see its branches in the gluteal region that you can differentiate most sacral plexus nerves. This is because all branches of the sacral plexus, as well as the piriformis muscle that originates on the anterior sacrum, exit the pelvis to reach the gluteal region. Then the relationships of the sacral plexus nerves to the piriformis muscle help identify individual nerves. For example, the superior gluteal nerve reaches the gluteal region by passing superior to the piriformis muscle, while the inferior gluteal and pudendal nerves pass inferior to piriformis. Now, once in the gluteal region, the pudendal nerve courses inferiorly to give off its inferior rectal branch in the anal triangle of the perineum. And then the pudendal nerve travels anteriorly to reach the structures of the urogenital triangle of the perineum. The sciatic nerve is huge and also exits the pelvis inferior to the piriformis muscle, but it's accompanied for a distance by the much smaller posterior femoral cutaneous nerve. The nerve to obturator internus and nerve to quadratus femoris really can't be seen without deep and detailed dissection, nor can the tiny segmental branches of the sacral plexus that supply the piriformis. Now let's generalize the functions of the various regions and compartments of the lower limb while we reiterate their nerve supply. Some gluteal muscles are laterally placed and abduct the hip, while others extend or rotate the hip. Those muscles are supplied by the sacral plexus nerves. The thigh has three muscular compartments: anterior, medial, and posterior. Muscles of the anterior thigh that cross the anterior hip act to flex it, as in kicking your lower limb forward. But muscles that cross the anterior knee act to extend the knee. Remember that knees and elbows are on backward in terms of action due to the lower limb rotation that occurs during development. Most muscles of the anterior thigh are supplied by the femoral nerve off the lumbar plexus. Muscles of the medial compartment of the thigh adduct the hip, and most are supplied by the obturator nerve off the lumbar plexus. All muscles of the posterior compartment of the thigh are supplied by some portion of the sciatic nerve off the sacral plexus. Muscles that cross the posterior hip largely act to extend the hip, like when you kick your thigh back. These same posterior thigh muscles cross the back of the knee and act to flex it. In the leg region, there are also three compartments, but this time an anterior, lateral, and posterior. All muscles below the knee are supplied by some branch of the sciatic nerve. Muscles in the posterior leg are all supplied by branches of the tibial nerve off the sciatic. Posterior leg muscles that cross the back of the knee act to flex the knee, and those that cross the posterior ankle plantar flex the ankle, like when walking on tiptoes. Some posterior leg muscles also act to flex the toes, like curling your toes. Muscles in the anterior leg do the opposite. Some extend the toes, like pointing them toward the ceiling, and some dorsiflex the ankle, as in heel walking. Muscles in the anterior compartment of the leg are supplied by the deep fibular nerve, which comes from the common fibular nerve off the sciatic. The lateral leg muscles are supplied by the superficial fibular branch of the common fibular nerve off the sciatic. The lateral leg holds muscles that evert the ankle, as in pointing the sole of the foot laterally. There are muscles in both the anterior and posterior leg that cross the medial ankle to invert the foot as well. Finally, muscles on the dorsum of the foot extend the toes and are supplied by the deep fibular nerve. Flexing the toes is a function of some muscles of the plantar foot, but many muscles of the sole of the foot have other functions. Regardless, all muscles of the plantar foot are supplied by the medial and lateral plantar nerves that come from the tibial branch of the sciatic nerve. Now, this summary shows that all muscles below the knee are supplied by some branch of the sciatic nerve. This review is also helpful to understand our clinical problem. A man received an intramuscular injection into his left buttock and quickly developed problems flexing his knee. In fact, all of his muscles below the knee were essentially paralyzed. Now, what nerve runs through the gluteal region and could be injured by a poorly placed injection into the buttocks? If you said the sciatic nerve, you're correct. That large nerve supplies the hamstrings of the posterior thigh that flex the knee, and by its branches, the sciatic also supplies all muscles below the knee. The man also had numbness and tingling in most skin of his left leg and his entire foot, but not in the anteromedial aspect of his leg, nor did he have issues in the skin on his thigh. Why? That's because the skin of the thigh is not supplied by the sciatic nerve. The femoral nerve's saphenous branch does go below the knee to supply the anteromedial leg, while all other skin of the leg and foot are supplied by branches of the sciatic nerve, the largest nerve of the body. Now let's use this information as we begin our journey through the lower limb, from hip to toes, covering the bones, muscles, joints, and movements, and see what other clinical situations we might run into. There's one final lower limb pun to wrap up this lesson.